Good afternoon to all. I am Dr. Snehangi, Junior Resident in Department of Psychiatry. Today I am presenting my seminar on psychotropic drugs used in the pregnant woman. I'll be covering the topic Introduction, General Principle of Prescribing Drugs, Psychosis in Pregnancy, Antipsychotic, Dose and their Side Effects, Depression in Pregnant Ladies, Antidepressant, Dose and Side Effect, Bipolar Affective Disorder, Mood Stabilizer, Dose and Side Effects, Anxiety, anxiolytics, dose and their side effect, and psychotropics in breastfeeding. So the lifestyle factors have an important influence on the pregnancy outcome. It is very well established that smoking cigarettes, poor diet, and drinking alcohol during pregnancy can have adverse consequences on the fetus. And psychiatric illness during pregnancy is an independent risk factor for congenital malformation, stillbirth, and neonatal deaths. Perinatal mental disorder are associated with risk for a broad range of negative child outcome. Affective illness, anxiety disorders, eating disorder, and other mental disorder increases the risk of preterm delivery. Note that preterm delivery is also associated with the risk increase of depression, bipolar disorder, and schizophrenia spectrum disorder in subsequent adult life. It is also important to note that pregnancy does not protect against mental illness and may even elevate overall risk in medication if stopped. In late pregnancy and early postpartum, there is an increased risk of relapse irrespective of medication use. General principle of prescribing drugs in pregnancy. First of all, we should always discuss the possibility of pregnancy because half of all the pregnancy are unplanned. Avoid using drugs that are contraindicated during pregnancy in women for reproductive age group such as valproate and carbamazepine. If mental illness is newly diagnosed in a pregnant woman, try to avoid all the drugs in the first trimester as major organs are being formed in the first trimester unless benefit overweights the risk, that is, and then use as established drug as lowest effective dose. The safety of the psychotropics in pregnancy cannot be clearly established because of prospective trials are obviously unethical and long-term observational studies are challenging to undertake. If a woman is taking psychotropic drugs and is planning a pregnancy, consideration should be given to discontinuing treatment if the woman is well and in a low risk of relapse. Discontinuation of treatment for women at high risk of relapse is unwise, but consideration should be given to switching to a low risk drugs. If the woman taking psychotropic medication discovers that she is pregnant, abrupt discontinuation of treatment post-conception for women with illness and at a high risk of relapse is unwise. Relapse may ultimately be more harmful to mother and child than continued effective drug therapy. Consider remaining with current medication that is effective rather than switching to minimize the risk of relapse. Valproate should be stopped. If the patient smokes, as smoking is very common in pregnant women with psychiatric illness, smoking has been associated with great proportion of excessive risk associated with poor pregnancy outcome. Always encourage switch to nicotine replacement therapy. Smoking has numerous adverse outcome. Referral to smoking cessation services is mandated by NICE guidelines. Stopping smoking can increase plasma level of certain drugs, for example, clozapine. So we should be very aware because of that also. In all pregnant women, ensure that the patient are as involved as possible in all decision. Use the lowest effective dose. Use the drug with the lowest known risk to the mother and fetus. Prescribe as few drugs as possible, both simultaneously and in sequence. Dose increase are frequently required in third trimester when blood volume expands by around 30%. Plasma level monitoring may be helpful wherever available. Note that hepatic enzyme activity changes markedly during pregnancy. Enzyme CYP2D6 activities increase by almost 50% by the end of pregnancy, while the activity of CYP1A2 is reduced by up to 70%. Consider referral to the specialist perinatal services. Ensure adequate fetal screening. Be aware of potential problem with individual drug around the time of delivery. Inform the obstetric team of psychotropics use and possible outcomes. Monitor the neonate for withdrawal effect after birth. Psychosis during pregnancy and postpartum. Pregnancy itself does not protect against the relapse. Psychosis during pregnancy predicts postpartum psychosis. The incidence of postpartum psychosis is 0.1 to 0.25 more in the general population. Women with bipolar disorder have an increased risk of postpartum psychosis, with around 1 in 5 experiencing a psychotic relapse postpartum. There is a high risk of relapse in women with a family history of postpartum psychosis or a personal history of postpartum psychosis. The risk of not treating psychosis includes harm to the mother through poor self-care or judgment, lack of abstracted care, or impulsive act, including suicide. They can also harm the fetus or the neonate, ranging from the neglect to infanticide. Beware that the drug-induced hyperprolactinemia like risperidone may prevent pregnancy. Consider switching to the alternative drug in hyperprolactinemia occurs and pregnancy is planned. If a pregnant woman is stable on an antipsychotic and likely to relapse without medication, advise her to continue the antipsychotic. Switching medication is generally not advised owing to its the risk of relapse. Consider using the antipsychotic that has worked best for the woman after discussion of benefits and risks. This may minimize fetal exposure by avoiding the need for higher dose if women relapse and or multiple drugs should relapse occur. Most reproductive safety data are available for quetiapine, olanzapine, risdone, and haloperidol. Quetiapine has a relatively low rate of placental passage. Advise pregnant women taking antipsychotic medication about the diet and monitor for the excessive weight gain. Women taking an antipsychotic during pregnancy should be monitored for gestational diabetes. NICE guideline recommends women be offered an oral glucose tolerance test. Antipsychotic discontinuation symptom can occur in neonates, which can be presented as excessive crying, agitation, increased suckling. When antipsychotics are taken in pregnancy, it is recommended that woman gives birth in a unit that has access to the pediatric intensive care facility. Some centers use mixed feeding to minimize the withdrawal symptom. Before starting the antipsychotic, I'd like to discuss about the FDA rating and category of the drug safety in pregnancy and lactation. Category A is no fetal risk in controlled human study. Category B is no fetal risk in animal study, but no controlled human study, or fetal risk in animal, but no risk in well-controlled human studies. Category C is adverse fetal effect in animals and no human data available. Most of our antipsychotic and antidepressant fall in the category C. And category D is human fetal risk seen may be used in life-threatening situation. Our benzodiazepine comes in this category. And category X, proved fetal risk in human, no indication for use even in life-threatening situation. L1 is the safest during lactation, L2 safer, L3 moderately safe, L4 possibly hazardous, and L5 is contraindicated. Now antipsychotics and the dosing with their category. First generation chlorpromazine is category C and L2. The range per day is 200 mg to 600 mg, and the normal adult dose is 200 to 800. Fluphenazine category C L2, range 2.5 to 20, and in adult is 0.5 to 40. Haloperidol category C and L2, range 5 to 30 mg per day, adult dose 1 to 40 mg per day. Perfenazine category C L2, range 12 to 24, and adult is 16 to 64. Fluoridazine category C L4, range 50 to 300, adult dose is 200 to 800. Second generation aripiprazole category C L3, range 10 to 30, adult dose 15 to 30 mg per day. Clozapine falls under category B and is L3, range 300 to 400, and in adult 25 to not exceed more than 900 mg per day. Olanzapine category C L2, range 5 to 10 mg per day, and in adult is 10 to 20 mg per day. Quetiapine category C and L3, range 300 to 400, adult dose 400 to 800 mg per day. Risperidone category C L3, 4 to 8 mg per day, and in adult is 2 to 16 mg per day. Some points regarding all the antipsychotics will be discussed now. Like in first generation antipsychotic, they are generally considered to have minimal risk of teratogenicity, although data are less than convincing as might be expected. In total, 20% of neonates exposed to first generation antipsychotic in the last week of gestation experience early somnolence and jitteriness. In a recent large American study including over a million women, no meaningful increase in the risk of major malformation or cardiac malformation was seen in 733 women prescribed on first generation antipsychotic. Neonatal dyskinesia has been reported with first generation antipsychotic, and neonatal jaundice has been reported with phenothiazines. In first generation haloperidol, first trimester exposure to haloperidol has been reported to cause limb defect, while cardiac anomalies are evidence in the third trimester. Other malformations that can occur with the use of haloperidol are microphthalmia, gastroschisis, and renal dysplasia. However, none of these are found to be significant when compared to the general population. In chlorpromazine, withdrawal and extrapyramidal side effects following third trimester exposure was seen. Fetal hypotonia may occur following a very high dose intake, an increased risk of neonatal jaundice in preterm infant. Zuclopenthixone, first trimester exposure lead to congenital cataract, congenital heart block, trichomalacia, hypospadiasis, undescended testis, pylorostenosis, and ureter stenosis. Some points for second generation antipsychotics are second generation antipsychotics are unlikely to be major teratogens. In a large American study including over a million women, no meaningful increase in the risk of major malformation or cardiac malformation was seen in 9,258 women who were prescribed on second generation antipsychotics. A prospective studies that include 561 women who took second generation antipsychotic, mostly olanzapine, quetiapine, clozapine, risperidone, and aripiprazole, during pregnancy concluded that second generation antipsychotic exposure was associated with increased weight gain, modestly increased risk of cardiac septal defect, and as with the first generation, withdrawal effects were seen in 15% of the neonates. Olanzapine has a risk of large for gestational age infant, risk of gestational diabetes, glucose monitoring is recommended. Olanzapine seems to be relatively safe with respect to the congenital malformation. Quetiapine is one of the second generation antipsychotic with the most experience in pregnancy, and it has the lowest placental passage of 23% associated with atrial septal defect, cleft lip or palate, pulmonary atresia, and hydrocephalus in the newborn. Spontaneous abortion are also reported in few cases. Risperidone, in a recent review of the safety of second generation in utero exposure, a small risk was observed with risperidone and paliperidone. Third trimester exposure to risperidone has resulted into extrapyramidal symptoms in infants. Clozapine is now included by NICE guideline in the medication that may be prescribed in the pregnancy. The use of clozapine appears to present no increased risk of malformation. Anyhow, some effects were seen such as floppy baby syndrome, gestational diabetes, risk of neonatal seizures, agranulocytosis in the fetus, and neonates are expected mostly in the theoretical concern. About the depot antipsychotic, there is very limited document evidence of the use of antipsychotic depot in the pregnancy. Therefore, they are best avoided where possible, given the potential for accumulation and toxicity in the neonates. However, NICE guidelines has suggested where a patient is stable and responding well to a depot antipsychotic and there is a history of non-compliance, it can be continued. Now, starting with the depression in the pregnancy, approximately 10% of pregnant women develop or have a pre-existing depressive illness. Around a third of case of postpartum depression begins before birth. There is a significant increase in new psychiatric episodes in the first 3 months after delivery. At least 80% are mood disorder, particularly severe depression. Women who had previous episode of depressive illness, postpartum or not, are at a high risk of further episode during pregnancy and postpartum. The risk is highest in women with bipolar illness who are also at the risk of mania or mixed affective episode. There is some evidence that depression increases the risk of spontaneous abortion, having a low birth weight or small for gestational age baby, or of a preterm delivery, though effects are small. The risk of not treating depression includes harm to the mother and harm to the fetus. Harm to the mother like poor self-care, lack of obstructive care or self-harm, and harm to the fetus ranging from neglect to infanticide. The dosing of the antidepressant along with their category. SSRI citalopram falls under category C and L2, range from 20 to 40 mg per day, which is similar to the adult dose range. Escitalopram category C, L2, ranging from 10 to 20 mg per day, and same with the adult dose range. Fluoxetine category C, L2, 20 to 80 mg per day, adult dose 20 to 80 mg per day. Paroxetine category D, L2, 20 to 50 mg per day, and adult dose is 20 to 50 mg per day. Sertraline falls under category C and L2, range from 50 to 200 mg per day, adult dose ranging from 50 to 200 mg per day. In TCA, amitriptyline category C L2 range is from 50 to 150 mg per day. Nortriptyline category D L2 range 25 to 150 mg per day. Desipramine category C L2 range from 50 to 200 mg per day. Imipramine category C L2 75 to 150 mg per day. In SNRI, desvenlafaxine, duloxetine, and venlafaxine falls under category C L2, and desvenlafaxine dosing is 50 to 400 mg per day, duloxetine 30 to 60 mg per day, and venlafaxine is 75 mg to 225 mg per day. Other antidepressant like bupropion falls under category C and ranges 150 to 450 mg per day, and in adult is 225 to 450 mg per day. Mirtazapines fall under category C, 15 to 45 mg per day. Trazodone category C, 150 to 400 mg per day. Some points regarding tricyclic antidepressants are neonates whose mother had taken tricyclic antidepressant until delivery has developed dyspnea, lethargy, colic, irritability, hypotension, and hypertension, tremors or spasm during the first few hours or days. Studies in animals have shown reproductive toxicity. Some authorities recommend the use of nortriptyline and desipramine if using tricyclic because these drugs are less anticholinergic and hypotensive than amitriptyline and imipramine. TCAs used during pregnancy increase the risk of preterm delivery. Use of TCA in the third trimester is well known to produce neonatal withdrawal effects like agitation, irritability, seizures, respiratory distress, and endocrine and metabolic disturbances, although these are usually mild and self-limiting. SSRIs appear not to be a major teratogens. Sertraline appears to result in the least placental exposure. Case control studies have reported an association between SSRI and anencephaly, craniosynostosis, emphysema, clubfoot, and increased umbilical cord length in newborn. Paroxetine has been specifically associated with cardiac malfunction, particularly after high dose, which is more than 25 mg per day in first trimester exposure. Exposure to selective serotonin reuptake inhibitor or SNRI during pregnancy is associated with increased risk of persistent pulmonary hypertension in the newborn. One small study reported abnormal general movements in neonate exposure to SSRI in utero. SSRIs may be associated with high risk of poor neonatal adaptation syndrome than SNRI. Increased level of anxiety symptoms have been reported in the exposed children. Women who have been taking antidepressant during pregnancy may be at increased risk of developing hypertension, preeclampsia, and postpartum hemorrhage. Other antidepressant like duloxetine is unlikely to be a major teratogen. Venlafaxine has been associated with cardiac defect, anencephaly, and cleft palate. Neonatal withdrawal and poor neonatal adaptation syndrome and PPH has been seen with venlafaxine. Second trimester exposure to venlafaxine has been associated with babies being born small for gestational age. Data suggests that both bupropion and mirtazapine are not associated with malformation, but like other SSRI may be linked to increased rate of spontaneous abortion. Mouse should be avoided in pregnancy because of suspected increased risk of congenital malformation and because of the risk of hypertensive crisis. Regarding the ECT in pregnancy, there is no evidence that suggests ECT cause harm to either the mother or fetus during pregnancy, although general anesthesia is of course not without risk. NICE recommends ECT for pregnant women with severe depression, severe mixed affective state or mania, or catatonia, whose physical health or that of the fetus is at serious risk. Bipolar affective disorder in pregnancy, the risk of relapse during pregnancy if mood stabilizing medication is discontinued is high. The risk of relapse after delivery is hugely increased. Women with bipolar illness are 50% more likely than control to have their labor induced by cesarean delivery, preterm delivery, and a neonate that is small for gestational age. The neonate is also more likely to have hypoglycemia and macrocephaly. This association holds true in both treated and untreated women. Bipolar illness itself does not seem to significantly increase the malformation rate. Any such association is with the mood stabilizing drugs. The risk of not using mood stabilizer include the same risk like discussed in antidepressant and antipsychotic, that harm to the mother through poor self-care, lack of obstructive care or self-harm, harm to the fetus or neonates. Now the dose and the category of the mood stabilizer, starting with the lamotrigine, category C, L3, dose 100 to 200 mg per day. Adult dose is 100 to 200 mg per day. Lithium falls on category D, and L4, dose starts from 300 and adjust dose as indicated by the plasma level, which is in mania 1.0 to 1.5. Carbamazepine falls under category D, L2, dose 200 to 1200 mg per day. Valproic acid should be avoided, but it falls on category D, L2, dose is 750 and it should not exceed 60 mg per kg per day. Uh, Lithium completely equilibrates across the placenta. Lithium should be avoided in pregnancy if possible. Monitor plasma level every 4 weeks until 36 weeks and weekly thereafter. Stop lithium during labor and check the plasma level 12 hours after last dose. Delivery should be in hospital and monitor fluid balance. Valproate, first trimester exposure to valproic acid is associated with high rate of malformation, more than 10%, including neural tube defect, effects on the cognition and brain volume, craniofacial anomalies, cardiac defect, cleft palate, and hypospadiasis. Valproate is by far the most dangerous drug at all stages of fetal development. Valproate must not be used in girls and women unless alternative treatment are not suitable and the pregnancy prevention program is in place. High dose of folate 4 mg per day is theoretically reduce the risk of neural tube defect. Second trimester ultrasound to screen the major congenital anomalies should be done. Blood level of valproic acid should be monitored. Carbamazepine risk of malformation are at 2.2 to 3.3%, primarily of spina bifida and other neural tube defect, as well as facial abnormalities, skeletal abnormalities, and hypospadiasis. Risk of neonatal hemorrhage is there. Consider giving maternal vitamin K. Consider high dose folate and screening for malformation. Best to be avoided in women who is planning pregnancy or she is pregnant or consider breastfeeding. Lamotrigine is the safer in pregnancy than carbamazepine and valproate. The association between exposure to lamotrigine and oral cleft are inconclusive. Lamotrigine levels may decrease over the course of pregnancy and thus should be monitored and adjusted if needed. Sedatives in pregnancy. Anxiety disorder and insomnia are commonly seen in pregnancy. Preferred treatment are CBT and sleep hygiene measure, respectively. First trimester exposure to benzodiazepine has been associated with increased risk of oral cleft in newborn. Benzodiazepine use in pregnancy may be a marker for cardiac and total malformation risk. Benzodiazepine have been associated with pylorostenosis and alimentary tract atresia. Benzodiazepine using in pregnancy has been associated with cesarean delivery, spontaneous abortion, neonatal intensive care admission, neonatal ventilatory support, low birth weight, preterm delivery, small head circumstance, and small for gestational age babies. Third trimester use is commonly associated with neonatal defects, mostly floppy baby syndrome. Data for Z drugs are limited. However, available data suggests that Z drugs are not associated with increased risk of congenital malformation. Zolpidem may be associated with increased risk of preterm delivery, low birth weight, increased likelihood of cesarean section. The categories that the benzodiazepines falls are alprazolam falls under category D and L3, chlordiazepoxide category D, L3, and if used chronically, it falls under L4. Clonazepam category D, L3, diazepam category D, L3, lorazepam category D, L3. Non-benzos like zolpidem category B, L3, zopiclone category C, L2 to L3, and zeleplon category C, L2 to L3. Now the second part of the seminar, that is breastfeeding and the psychotropics. Data on the safety of psychotropic medication in breastfeeding are largely derived from a small studies or case report and case series. Reported infants and neonatal outcome in most cases are limited to short-term acute adverse effect. Long-term safety cannot there be guaranteed for the psychotropic. All psychotropics are excreted in breast milk to varying degree. The most direct measure of infant exposure is of course infant plasma level, but this data are rarely available. Instead, many publication reports only drug concentration in breast milk and in maternal plasma. Maternal plasma level of antipsychotic may be useful estimate of infant exposure. Breast milk drug concentration can be used to estimate the daily infant dose by assuming a milk intake of 150 ml per kg per day. The infant weight adjusted dose when exposed as a proportion of the maternal weight adjusted dose is known as relative infant dose. The RID should be used as a guide only as values are estimated and this estimates varies widely in the literature for individual drugs. Drugs with RID below 10% are usually regarded as safe in breastfeeding. Where measured infant plasma level below 10% of average maternal plasma level has been also proposed as safe in breastfeeding. General principle of prescribing psychotropic in breastfeeding. The safety of the individual drug in the breastfeeding should be taken in account when prescribing psychotropic medication for women considering pregnancy. Discussion about the safety of drug in breastfeeding should be held as early as possible, ideally before conception or early in pregnancy. Decision about the use of drug in pregnancy should include the discussion about breastfeeding. Switching drugs at the end of pregnancy or in the day after birth is not advisable because of high risk of relapse. When a mother has taken a particular psychotropic drugs during pregnancy and until delivery, continuation with the drug while breastfeeding will usually be appropriate as this may minimize withdrawal symptom in the infant. In each case, the benefit of breastfeeding to the mother and infant must be weighed against the risk of drug exposure in the infant. It is usually inappropriate to stop breastfeeding except when the current prescribed drug is contraindicated in breastfeeding. As treatment of maternal mental illness is the priority, in such cases treatment should not be withheld, but the mother should be advised to bottle feed with formula milk. When initiating a drug postpartum, it is important to consider the mother's previous response to the treatment. Best to avoid a psychotropic with high reported infant plasma level or high RID. Important to consider the half-life of drug. Drug with long half-life can accumulate in breast milk and infant serum. Neonates and infants do not have the same capacity for drug clearance as adults. Premature infants and infants with renal, hepatic, cardiac, or neurological impairment are at high risk for the exposure of the drug. Infants should be monitored for any specific adverse effect of the drug as well as for abnormalities in feeding pattern and growth and development. Infant plasma levels should be monitored if adverse effects are noted or toxicity is suspected. Women receiving sedative medication should be strongly advised to not breastfeed in bed as they may fall asleep and roll onto the baby with a potential risk of hypoxia to the baby. Sedation may affect a woman's ability to interact with their children. Women receiving sedating drugs should be monitored for this effect. Wherever possible, use the lowest effective dose. avoid polypharmacy, continue the regime prescribed during pregnancy. Now discussing about the antidepressant in breastfeeding, like citalopram, infant plasma concentration is almost undetectable up to 10% of maternal plasma level. High citalopram's level is higher than fluoxamine, sertraline, paroxetine, and escitalopram, but lower than fluoxetine. RID is 3 to 10%, meaning it is safe in the breastfeeding. Reported acute adverse effect in infant were seen as sleep disturbances, which resolve on uh, uh, halving the maternal dose. Colic, decreased feeding, and irritability and restlessness were also reported. Reported developmental effect in infants were not reported as such with citalopram. Bupropion infant plasma concentration is undetected or low. RID is 0.2 to 2%. Two reports of seizure-like activity in 6-month-old and one case of infant experiencing cell disturbance, somnolence, and severe emesis. No report of developmental effect in infant. Duloxetine infant plasma concentration is less than 1%. RID is less than 1%. Reported adverse effect are dizziness, nausea, fatigue, and there is no report about the developmental effect in the infants. Escitalopram infant dose is undetectable or low. RID is 3.8 to 3%, and adverse effect that was reported was necrotizing enterocolitis in 5-day infant who was exposed in utero. Seizure-like activity is reported, sleep disturbance, severe emesis, and somnolence. No infant developmental effects were reported. Fluoxetine infant plasma level variable can be up to more than 10% of the maternal plasma. Highest reported level of SSRI is seen in fluoxetine. RID is 1.6 to 14.6. Adverse effects seen are colicky, excessive crying, decreased sleep, diarrhea, vomiting, somnolence, feeding, hypotonia, grunting, and hyperactivity. Um, One retrospective study found lower growth curve, and fluoxamine infant plasma level is undetectable to up to the half the maternal plasma level, RID 1 to 2%. Adverse effects seen are neonatal jaundice, severe diarrhea, mild vomiting, decreased sleep, and agitation. No reports are there regarding the developmental effect on the infant. Mirtazapine infant plasma level undetectable or low. RID is 0.5 to 4.4. An adverse effect that was reported is in a study of 54 infants exposed to mirtazapine in utero, the incidence of poor neonatal adaptation syndrome was significantly diminished in those who were breastfeeded. No abnormalities reported in developmental effect in the infants. Paroxetine infant plasma level is undetectable or low. RID is 0.5 to 2.8. Adverse effect like vomiting, irritability, which were attributed to severe hyponatremia, insomnia, restlessness, and constant crying are reported. And there is no report about the developmental effect on the infant. Sertraline infant plasma level is undetectable or low. RID is 0.5 to 3, and adverse effect is serotonergic overstimulation report in preterm infant also exposed to serotonin in utero. Symptoms include hyperthermia, shivering, myoclonus, tremors, irritability, high-pitched crying, decreased suckling reflex, and reactivity. Withdrawal symptoms like agitation, restlessness, insomnia, and an enhanced startle reaction has developed in breastfed neonates. After abrupt withdrawal of maternal sertraline, the neonate was exposed to the sertraline in utero. No developmental effects were reported on sertraline. Venlafaxine infant plasma level undetected and up to 37% of the maternal plasma level, RID 6 to 9%. Adverse effect lethargy, jitteriness, rapid breathing, poor suckling, dehydration in infant also exposed in utero. Symptoms subside over a week on breastfeeding. Authors suggest that breastfeeding may have helped manage infant withdrawal symptom postpartum. No report of developmental effect on the infant. About vortioxetine, no published data are yet available. TCAs are undetectable or low and the infant plasma level. RID is 1 to 3%. Adverse effects have not been reported in infant exposed to nortriptyline, clomipramine, imipramine, desipramine through breast milk. Severe sedation and poor feeding report with amitriptyline. Poor suckling, muscle hypotonia, drowsiness, or respiratory depression reported with doxepin. No report on the developmental effect on the infant. Antipsychotics in breastfeeding, amisulpride infant plasma concentration 10.5% of the maternal plasma concentration, and RID is 4.7 to 10.7. Acute adverse effect is not reported and developmental effect in infant is also not reported. Aripiprazole 4% of the maternal plasma concentration, RID 0.9 to 8.3. Acute adverse effect not reported, developmental effect is not reported. Clozapine infant plasma concentration 6.5% of maternal plasma concentration, RID 1.4%. Acute adverse effect were sedation, agranulocytosis, decreased suckling reflex, irritability, seizure, and cardiovascular instability. One report of delayed speech was there with clozapine. Lurasidone, no published data available. Olanzapine is undetectable or low. RID is 1 to 1.6%. Adverse effect like somnolence, drowsiness, irritability, tremors, insomnia, lethargy, poor suckling and shaking. One case of lower developmental age than chronological age and one case of speech delay. Quetiapine is undetectable in infant plasma level and RID is 0.09 to 0.1. Adverse effect seen was excessive sleep and 2 cases of mild developmental delay was reported. Phenothiazine, the infant plasma level are variable and RID is 0.3% in chlorpromazine. Side effects were lethargy and delayed development in 3 infants were reported. Risperidone is also undetectable in infant plasma level and the RID of risperidone is 2.8 to 9% and N-hydroxyrisperidone is 3.4 to 4.7. One case of one case of hypersomnia, poor feeding and slowing in motor movement and no report of developmental effect on the infant was noted. Haloperidol infant plasma level is not reported and RID is 0.2 to 12%. One case of hypersomnia, poor feeding and slowing in motor movements. Delayed development was noted in 3 infants exposed to combination with chlorpromazine. Mood stabilizer, carbamazepine has generally low infant plasma concentration. RID is 1.1 to 7.3%. Adverse effects have not been reported, but there was one case of polycystic hepatitis, transient hepatic dysfunction, and seizure-like activity, and 2 cases were reported of poor suckling, poor feeding, and hyperexcitability. Study concluded no effect on the developmental effect in the infant. Lamotrigine undetected to 48% of maternal plasma level. RID is 9.2 to 18.3. No adverse effect have been reported in a number of infants, but seven cases of thrombocytosis, 1 case of severe cyanotic episode, 3 cases of rash. No abnormality reported in the development effect in infant. Lithium undetectable to 57% of maternal plasma level. RID is 12 to 30%. Adverse effect, early feeding problem, increased urea, raised creatinine, and 1 case of raised TSH. Developmental effect in infant is not reported. In valproate, the infant plasma concentration is less than 2% of the maternal plasma level. RID is 1.4 to 1.7%. Thrombocytopenia and anemia which reverts on stopping breastfeeding. Study concluded no effect on the developmental effect in the infants. Hypnotics in breastfeeding, benzodiazepine, infant plasma concentration not reported. RID of clonazepam is 2.8%, diazepam is 0.8 to 7.1%, lorazepam is 2.6 to 2.9, oxazepam is 0.28 to 1%. Reported acute adverse effect in infants with benzodiazepine are sedation, lethargy, weight loss, mild jaundice, and 1 case of persistent apnea with clonazepam was reported. restlessness and mild drowsiness with alprazolam, and no adverse effect has been reported in others. The Z drugs, zopiclone, zolpidem, and zaleplon, there is infant plasma concentration is not reported. RID of zopiclone is 1.5%, zolpidem is 1.5%, zaleplon is 0.02 to 0.18%. Acute adverse effect is not reported, and developmental effect is also not reported. To summarize the to summarize my seminar, the mental health of the mother influence fetal well-being, obstructive outcome, and child development. Ensure that the patient are as involved as possible in all decision. Use the lowest effective dose and use the drug with the lowest known risk to the mother and fetus. Women who are at high risk of relapse are best maintained on the same antidepressant during and after pregnancy. When initiating an antidepressant in a woman planning pregnancy, previous response must be taken into account. Sertraline is the best option. No clear evidence that any antipsychotic is a major teratogen. Consider using or continuing drug mother have previously responded well to rather than switching prior to or due to pregnancy. Screen for adverse metabolic effect. Offer women an oral glucose tolerance test. Arrange for women to give birth in a unit with access of neonatal intensive care facilities. When initiating an antipsychotic in women planning pregnancy, previous response must be taken into account. Quetiapine has relatively low rate of placental passage. Valproate should be stopped if a woman becomes pregnant, where medication history clearly shows that no other agent have been effective, and that if valproate is stopped, the woman will relapse. A careful risk-benefit analysis must be concluded. The woman must understand the risk of valproate using in pregnancy, avoid other anticonvulsants unless risk and consequences of relapse outweigh the known risk of teratogenesis. Consider using mood-stabilizing antipsychotic. Lamotrigine is also an option in the bipolar depression and mania as well. Benzodiazepine, zopiclone, and zolpidem are probably not teratogenic but are best avoided in late pregnancy. These are my references, and thank you for your patient listening.